Good afternoon, everyone. For those of you who are joining us online, just wanted to let you know that we will be starting in about a minute. Thank you. Hello. Hello, good afternoon, everyone. Welcome to everyone who's joining us here in person, and also, I think that's a camera. Thank you for joining us online today. My name is Isabella, and I'm a research fellow here at the George Institute, and this is...
Hi, I'm Sonali Gnanenthrian. I'm also a research fellow at the George Institute.
And we are your chairs today for the March CVRN Rising Stars seminar. So thank you once again for joining us today. Before we start, I just want to acknowledge the traditional owners of the land that we are standing on today, the Gadigal people of the Eora Nation, and we wanted to extend a warm welcome to any Aboriginal or Torres Strait Islanders in our midst today, and also for those of you who are joining us online. So before we get into the talks, so just wanted to quickly introduce CVRN to those who may not be familiar with CVRN. So CVRN started back in 2005 when we have 14 umbrella organisations with over 600 members across New South Wales. So these are the names of all our Rising Stars subcommittee members. You may recognise some of them. And these are just some of our faces, so you can put a face to the name. So without further ado, I'd like to start today's seminar. The theme of today's seminar is Pulse Perspectives, from lifestyle precursors to blood pressure measurement and medications. I'll hand over to Sonali.
So it gives me great pleasure to introduce our first speaker, Dr. Dean Picone. So he's a senior research fellow at the School of Health Sciences, the University of Sydney. He holds an NHMRC Emerging Leader Fellowship, and he's also an adjunct senior researcher at the University of Tasmania and the chair of the New Investigator Committee of the International Society of Hypertension. So he's going to give us a talk on blood pressure measurement, the good, the bad, and the ugly.
Thanks, Sonali, and thanks for having a fairly new New South Wales person come and talk to you, largely about work that I've completed in Tasmania, but we'll sort of be continuing some of this up here. So I better get into it or I'll run out of time. So the good, the bad, the ugly. So methods of blood pressure measurement can sort of simply be sort of categorized into two sort of main measurement methods. The cuff, which everyone's probably heard of, the one that inflates around your arm. You have automatic methods, which can be used in the clinic, or 24-hour methods, or you can use it at home with self-measurement of blood pressure. The manual method is the one where the doctor also puts a stethoscope on, or the nurse, and listens for sounds, and that's typically measured in clinical environments. I'm just introducing invasive blood pressure measurement now as well, because I'm going to talk about that a little bit later. So that's performed by inserting a catheter inside the artery and gives you a reading of the measurements from wherever that catheter is sitting. That's obviously highly invasive, and these days is only used in hospital procedures. So I'll start with the good about blood pressure monitoring. And these are just sort of some broad perspectives. It's a cheap tool for screening, diagnosis and follow-up of high blood pressure. And there's decades of evidence showing that the upper arm cuff measured blood pressure has strong associations between high cuff BP and risk of adverse events, and that there's highly effective treatments that if you lower cuff measured blood pressure, you lower risk. This is some of the first data. It was actually from 1914 from a life insurance company. And they were reporting on assessing risks, which is essentially whether they gave someone insurance or not. And they found that a blood pressure above systolic of 150 was associated with all-cause mortality. More recently, we have large-scale epidemiological studies showing a log linear relationship between systolic blood pressure and risk related to ischemic heart disease and stroke, and also large meta-analyses from blood pressure trialist data showing per 10 millimetre of mercury reduction in blood pressure, we have large reductions in CV events, coronary disease, stroke, heart failure. The other good thing about the cuff measurement, it's enabled us to really better understand physiology related to blood pressure measurement. As an example, circadian rhythms of blood pressure and nocturnal blood pressure. So, for example, this is probably not the best plot, but if we look at here at the daytime blood pressure or also across the year, we see marked variations across a 24-hour period and even across seasons. So really, in summary, it's a critical tool to inform the management of high blood pressure and cardiovascular risk. So this presentation and what I'm about to talk about isn't intending to undermine that at all. So what about the bad? Oh, someone's getting a phone call. Wasn't me. There's 29, this systematic review reported on 29 sources of error related to clinic blood pressure measurement that was summarised as patient-related, device-related, procedure-related or observer-related. So patient-related might be they've drank caffeine, had a cigarette just before taking a measurement. Device-related is related to the intrinsic measurement device. Procedure-related might be example with the white coat hypertension where you've got in-clinic measurements not reflecting the true blood pressure. And observer-related could be a doctor measuring a blood pressure with a stethoscope and they actually have really bad hearing, so they can't hear the sounds. This consortium was started during my PhD. I performed a large-scale systematic review and individual participant data meta-analysis to try and understand cuff blood pressure accuracy compared to that gold standard invasive blood pressure. And this sort of came about through us exploring alternate ways to measure blood pressure related to pulse wave analysis techniques. I'm not going to talk about it all today. So essentially what we found in this set of work was that there's age-dependent relationships between the accuracy of cuff blood pressure. So you can see the cuff overestimating blood pressure when it's above that zero line or underestimating when it's below. So age-dependent relationships in systolic and diastolic blood pressure. We've also observed that there are differences between women and men where women, particularly at older age, tend to have underestimation of cuff pressure compared to the invasive reference standard. And so this work is sort of ongoing with collaborators in Tasmania. We're trying to understand really critically if we can actually improve the accuracy of cuff measured blood pressure. But the thing that's sort of of most interest to me and important to me is to understand if actually having a more accurate measurement will improve prediction of major adverse cardiovascular events, because the studies that we've conducted in people with invasive blood pressure are studies of people who are already at quite high risk. And so we have some mechanisms to try and understand this on a larger scale through this work. We're still currently recruiting through Cath Labs, so if you know anyone that might be interested, we're always looking for new sites to participate in this clinical research protocol. I just also want to add that not all cuff measurements are created equal. So this is a large paper that was published recently with tens of thousands of measurements of clinic blood pressure, so in the doctor's office, and 24-hour ambulatory blood pressure measurements. So that's where the cuff's applied to someone's arm and they wear it for a 24-hour period. And if you look at the blue there, you can see that's nighttime or nocturnal blood pressure, and the green is daytime, and the black is clinic measures. So this study essentially concluded that daytime and nighttime blood pressure were much, much, much more predictive of death than clinic blood pressure. So even though we've got the same method, we're using it at different times of the day, there's different circumstances underlying it, and we get very different relationships to adverse outcomes. And just as an interesting side note, the 24-hour blood pressure measurement method potentially can also be improved greatly. About 1 in 4 individual measurements from these devices actually show major artifact. And that when you look at the measurements with artifact compared to those without, there's significant differences in daytime blood pressure up to about 6 millimeters of mercury, which is quite large. I guess there's key questions from that is if we had more accurate measurements of 24-hour BP, would that actually be useful, and would predictive power of 24-hour BP be even better? Or maybe it doesn't matter at all. We don't actually know the answer to that. So for the ugly, I'm kind of going to switch away from physiology work and just talk briefly about some other stuff that I've done more recently, which is related to the blood pressure device marketplace. And a couple definitions quickly. Device validation studies, so they are essentially rigorous clinical testing of an automatic blood pressure device according to a standardised protocol. That's not done compared to invasive blood pressure. And a validated device is simply one of these devices that's actually passed the validation protocol requirements. So to summarise this work in a nutshell in one slide, we found that most blood pressure devices available globally have no evidence of clinical validation. So there's only 24% of devices globally that have evidence of passing accuracy criteria, and 15% of devices in Australia. So that might be a bit confusing to you, but the key reason for that is that regulators don't require clinical accuracy testing for these devices to gain pre-market approval. That's the case in Australia, that's the case in basically every country in the world except for Cuba, which now manufactures its own blood pressure device and has outlawed any other devices unless they're validated for accuracy. One of the key other findings from this sort of body of work is that the devices that have no evidence of validation are much cheaper compared to the ones that have undergone the testing, and that may influence consumer choices, but we don't actually know that. There are some sort of mixed methods studies in small populations that suggest that might be the case. Others suggest doesn't matter so much, so it's an area of interest to explore a bit further. And the consumer ratings through an analysis we did of the Amazon marketplace show that the ratings are exactly the same between devices that had undergone validation testing and those that hadn't. It's also very difficult to identify validated devices compared to those that aren't. You can't just rock up to the pharmacy and they're all accurate, because that's, or at least have undergone accuracy testing. That's not the case. So in the meantime, we need to try and do something to direct consumers towards validated devices. And this was some work that was done in collaboration with some international colleagues in the Pan American Health Organization. We developed some resources to try and help direct people to understanding how they could find an accurate device, or if they're using one, understand if it had been tested for accuracy. Done some sort of fun awareness sort of type campaigns where I've been in Zoom calls with people talking Spanish and Portuguese and translation in real time going on, which was all very interesting in the middle of the night during the COVID years. And have also participated or sort of co-led a regulatory document which essentially provides recommendations to the Hearts in the Americas program, which is a large cardiovascular risk reduction program being rolled out in a number of countries in that region, trying to ensure that when they are implementing this program in primary care, that they're using devices that have met accuracy guidelines. So to summarise, there's lots of good related to the best standard blood pressure measurements that we have, the cuff. There's some bad, or there's room for improvement, potentially, at least in accuracy compared to true invasive blood pressure, but whether that means it will improve risk prediction, we don't know. And the ugly is that there's lots of devices available primarily for patient use that have no evidence of basic clinical accuracy testing, which can kind of be thought of as a minimum quality criteria. That has the potential to lead to mismanagement of hypertension. So there's stricter regulations and awareness needed, which is sort of ongoing work, really. Finally, a quick plug for the ISH meeting. As Sonali mentioned, I'm involved in this organisation. They're having their meeting in Cartagena in Colombia in September. We're organising a capacity building network symposium the day before. Abstracts are due April 30. If you're keen, it'd be great to see you there. Thanks.
To Jialing. So she is an early career researcher and an epidemiologist based at the Medicines Intelligence Research Program at the University of New South Wales. Her research focuses on using large administrative health data sets and survey data to understand real-world use, benefits and harms of medicines and vaccines. And currently she's exploring the use of cardiometabolic medicines in Australian communities. So she's going to give us a talk on impact of coordinated care on adherence to antihypertensive medicines among adults experiencing polypharmacy in Australia. Thank you.
Thank you for the great intro, and thank you people being here today to join this seminar. Let me skip this. I will start from the background of my research. As you know that like antihypertensive medicine is the key for the management of hypertension, and clinical guidelines always recommend people taking multiple antihypertensive medicines to achieve aggressive blood pressure control. And people with hypertension often have some comorbidities such as diabetes, heart failure, COPD, and it is reported that more than half have at least one additional comorbidity. As such, this population often taking a large number of medicines. And this can cause a very complex care pathway for these people that will involve multiple healthcare professionals. And medicine adherence is a cornerstone for optimizing treatment outcomes for hypertension, but it can be very challenging for people with a very complex care regimens. As I mentioned before, like people with hypertension often need to have different providers such as primary care, specialist care, pharmacies, and it is very easy that because of these too many providers involved and fragmentation of care will be easily occurred in this population. Therefore, we need to consider how to coordinate care for this population. And coordinating patient care can be tricky, but it can also be resolved in different perspectives. Like firstly is to simplify medicine regimens, like in terms of the dose forms and daily dose frequency, because these people are having a high burden of medicine. They're taking a lot of medicine every day. And secondly, it can achieve by like synchronized prescribing and dispensing activities to consolidate healthcare interactions. And therefore, people don't have to visit the pharmacies many times in different days. And particularly, people living in rural and remote areas, they have limited access to pharmacies. Therefore, and currently in the existing literature, that there are evidence so that these individual measures can improve the medicine adherence. However, it is a limited evidence on the measure of the effect of how the effect of these multiple measurements. And then we kind of want to assess the effect of multiple measures of coordinated care on adherence to antihypertensive medicine in people who are using a lot of medicines. And we use data from the pharmaceutical benefits scheme that include dispensings of subsidized medicine, and we used a 10% sample of this data. And the study design would be a retrospective cohort study that we included people who have at least one antihypertensive medicine during July 2018 to June 2019. And then we restrict the cohort to people who with polypharmacy, that we define this using a 90 days look back period, and that they having at least 5 or more unique medicines. And then we use the same look back period to calculate the measures of these different coordinated care. And then from the day of the first observed dispensing of antihypertensive medicine, we start to follow up this patient from this day and then to the day of that and the 1 year observation period, whichever occurred earlier. And for this study, we look at first-line antihypertensive medicine, including 4 classes: the angiotensin converter enzyme inhibitors, angiotensin receptor blockers, calcium channel blockers, and thiazide and thiazide-like diuretics. And the exposure is the measures of coordinated care. They're reflecting medicine management. The first one is a simple cardiovascular regimen that we define it as people taking 1 pill a day for their cardiovascular medicines. And it was derived from the complexity medication score, which include 2 components, is the dose form and daily dosing frequency. However, because of the limited time, I can't get into details of this. If you are really interested, please do get in touch. And the second one is prescriber continuity, is to calculate the proportion of all medicines that patient dispense from the most common prescriber. And based on the existing literature and the data distribution, we define it as 0.75 of dispensing from the most common prescriber as high continuity. And the last one is dispensing coordination. It is the proportion of all medicine dispensed on the same day as 1 or more other medicines. It can reflect the extent to which filling of prescription aligned with at least 1 other medicines. And similarly, we define it based on the data distribution and previously papers, and we use a threshold of 0.5 for this. And the outcome is adherence. We use a very common measure for this, which is called the proportion of days cover. Is to calculate the proportion of the days that people having access to antihypertensive medicine during their whole follow-up period. And again, we use a threshold of 0.8 for high adherence, because studies show that people having a proportion of days covered than more than 0.8, they have more cardiovascular protective effects. And also similarly, because I don't have really enough time, so I will not talk into the details of this proportion of days cover. And then we use a logistic regression to assess the independent association between each measure and also the multiple measure on adherence. And overall, we included about 202,000 people who were experiencing polypharmacy and also having antihypertensive medicine. And the median age of this cohort is 71 years old, is a bit old. And then half of them were female, and the median number of comorbidities of this cohort was 5, and median number of the medicine they take was around 7, and the most common antihypertensive medicine of the index dispensing was ARB, and half of them were dispensed at least 3 unique cardiovascular medicines in the last 3 months. And this table and the upset plot shows the prevalence of these different measures of coordinated care. You can see that for this individual measure, and approximately 2/3 of people are experienced. And then only like 1/3 of them experience all of the 3. But if you look at the figured upset plot here, you can see the very most common combination is people having all of these 3 measures. And this table shows the independent measure for the independent association between each measure. You can see that simple cardiovascular regimens were associated with decreased adherence in the unadjusted model. But after we adjusted for age, sex, number of comorbidities, and the other measures, the direction changed, and it was associated with increased adherence. And for prescriber continuity and dispensing coordination, the direction is quite consistent in both the crude and the adjusted models. They were associated with increased adherence. And this figure kind of show the effect of the multiple measures. And you can see that there is a kind of obvious trend in adherence with the number of measure of coordinated care, that people having the higher number of measure, and they are tended to have higher adherence to antihypertensive medicines. And also you can see that all these the combinations that involve dispensing continuity or dispensing coordination or prescriber continuity, they were all associated with increased adherence, except the combination that had only simple cardiovascular regimens, which is kind of expected, because like in the study we found that like more than 90% of the cardiovascular dispensings were taking one pill a day. And these results were consistent with the prior studies that look at this individual measure. And in summary, we find that care coordination in people using treated for hypertension can help to increase adherence. And the effect was strongest in people using multiple strategies to consolidate both their prescribing and supply of medicines. And our findings also support that the development of multiple strategies of very comprehensive medicine management, which is kind of a bit line with Nick's research fund from clinical trials, that for these people using a large number of medicine can help to increase their medicine adherence. Last but not least, I really like to thank all of my collaborators from both University of New South Wales and University of Sydney and the funders. Thank you very much.
Thank you so much, Jialing, for that really wonderful talk. I do have some questions for you, but I'll wait till the end. It is with great pleasure that I now invite Dr. Mengyun from the University of Sydney at the Charles Perkins Centre. So Dr. Luo finished her PhD degree just at the end of last year, so congratulations, and yay! And now she's currently working as a postdoc research fellow, as I mentioned, at the Charles Perkins Centre, looking at the systems thinking to understanding physical inactivity as well as the risk factors associated with that in Australia. So her PhD focused on the lifestyle behaviours using multiple large open access data sets, whereas now her focus is in Australia. So her own research interest is about promoting healthy lifestyle choices and behaviour, in particular physical activity amongst older populations in low to middle income countries. So I'll let Dr. Law introduce her talk. Thank you.
Thank you, everyone. Thank you for having me here today. So yeah, my name is Mengyun Law. You can call me Susan. I think it's much easier. And I realized I have got the longest title today. So instead of reading it again, I know it's a bit confusing. I would ask you guys a question. So let's say we have got two groups of middle-aged adults. So one group are those people with high genetic risk of developing type 2 diabetes while they are very active in their daily life. And then we have another group of participants or people, they have a very low genetic risk while they are very inactive in their life. Like in general, they are very sedentary. So which group do you think have got a higher risk of developing type 2 diabetes in maybe the next decade? You don't need to tell me the answer now. Let's explore it together, and hopefully at the end we have the answer. Yeah, before I start, I want to acknowledge the traditional owner of the country and pay my respect to the elder past and present. So as we all know, diabetes is one of the global public health concern. And in 2021, there were 537 million adults living with diabetes all around the world. And we also know that diabetes can cause a lot of serious health problems like heart attack, heart failure, stroke, etc. And all these complications can lead to death, which makes type 2 diabetes, diabetes one of the top 10 leading cause of death by disease worldwide. And actually here in Australia, it's the 7th leading cause of death. Besides the negative health effect it brings, diabetes also has shown have got substantially health burden to the whole society. And actually in 2021, it was reported that the direct health expenditure related to diabetes ascended to $1 trillion worldwide. And in Australia only, it was $20 billion already. So unfortunately to date now, the exact cause of type 2 diabetes is still a bit unclear. And it was predicted that the number of people living with diabetes in the coming future is gonna keep growing. So it's a really serious health problem, and we really need to look into how to prevent people developing type 2 diabetes, which is a quite critical and urgent topic. And type 2 diabetes accounted over 90% of all types of diabetes. Apparently, physical activity is well recognized as a first-line strategy to prevent type 2 diabetes. And you might have seen this before, which is the WHO guideline on physical activity and sedentary behavior. WHO suggested about 30 minutes of moderate intensive physical activity on most days of the week, as you can see here. However, the current recommendations relies exclusively on questionnaire-based self-reported data, which these two are actually the most commonly used one. The International Physical Activity Questionnaire, in short IPAC, or Global Physical Activity Questionnaire, GPAC, which is very good because it makes it very easy to measure. As long as people have a pen and a paper, you can ask them to answer the questions. However, we also realize that it is subject to a lot of bias because it can be easily underreported or overreported, due to recall bias or due to meeting the social desirability. And on the other hand, we know that genetics plays a very important role in the etiology of type 2 diabetes. However, little has been discussed about if the genetic risk of type 2 diabetes can be attenuated by physical activity, and also if the protective effect of physical activity differs between different groups of genetic risk. So here, in order to answer these questions, we carried out this current study to examine the prospective dose-response relationship between physical activity and the incident type 2 diabetes, accounting for genetic risk. And also here, in order to solve the problem about reporting bias, we use accelerometer instead of the questionnaire, as I mentioned before. And also, besides looking at only moderate to vigorous physical activity, we also want to have a look at the effect of physical activity with only light intensities, like we do daily work with the family. At the same time, we also want to test whether the association between physical activity and incident type 2 diabetes across different genetic risk groups, and also want to examine a bit about if we put them together as a combination, what's going to be the result. So in order to answer these questions, we use the data from the UK Biobank. So as you might know or might not know, UK Biobank recruit over 500,000 participants between 2006 to 2010, and they did a follow-up study to use accelerometer to measure physical activity in 2012 to 2013, but with a subsample around 100,000 participants. As accelerometer measurement is the aim of the current study, so we limit that to a smaller sample of the participants and also exclude those people who are not eligible for the current study. For example, people who has got type 2 diabetes already before they do the accelerometer measurement. So as you can see at the very bottom, the final sample size was 59,325. As I mentioned before, we use accelerometer to measure the physical activity variables, which including total physical activity, which is in milligravity. Also, we measured moderate to vigorous physical activity, along with low intensity physical activity in hours per day. We also generate the polygenic risk score using 424 selected SNPs associated with type 2 diabetes, which is the most comprehensive one up until 2022 when we carry out this study. I realized that there were new results or new GWAS studies coming out now using other data sets. So I think this number is gonna keep increasing in the coming years. And based on the PRS, we categorize people into 3 different groups, genetic risk groups, so which named as low, intermediate, or high using tertile. And the outcome measure was the incident type 2 diabetes based on code E11 from ICD-10. So regarding the analytic methods, we performed Cox proportional hazards model, adjusting for a wide range of confounders, including social demographic characteristics, for example, sex, social, educational level, income level, and also non-physical activity lifestyle risk behaviors, including smoking, drinking, and diet. Also pre-existing chronic conditions, accelerometer-related variables, and also genetic risk. In addition to that, we also add a multiplicative interaction term in our model to test if genetic risk is an effective modifier. At the end, we combine physical activity levels with the genetic risk groups. So there will be 12 groups in total. And then we use the highest risk combination as the reference group and to see how the result is gonna be. So here are the results. So the first on this slide, it's a result of the restricted cubic slide. So this is actually showing or test if there is a nonlinear relationship between physical activity and the incidence of type 2 diabetes. And as you can see, there are 3 small figures here, which is about total physical activity, MVPA, and LPA. So the 3 independent variables we measure. As you can see, we didn't observe any nonlinear one. As a result, we categorize people's physical activity level using the 10th, 50th, and 90th percentile. And let's have a look at the fully adjusted model. So regarding the total volume of physical activity, you can see that compared to the least active group, which is the top group here, those who are at the top percent, which means that they are the most active ones, has got 68% lower risk of developing type 2 diabetes. Also, we find significant result for the middle groups as well. So as you can see, if you are the more active, actually the better. And we observe the similar pattern for moderate to vigorous physical activity as well, with even stronger effects. But if we have a look at the low intensity physical activity, we observe the only statistically significant result in the most active group, which is the top 10 active group. As I mentioned before, we also want to combine these groups together and to see how the results is going to look like. So as you can see, the first group on the left, which is the highest risk group, who are people with high genetic risk, and also they are the least active ones. Compared to this group, all the other groups showed some sort of protective effect. But interestingly, if we compare these two groups, we actually found out, compared to those people who are having low genetic risk, but also they are the least active ones, those people who are having high genetic risk, but they are the most active ones, have got a lower risk of developing type 2 diabetes. And not surprisingly, we find a similar pattern for moderate to vigorous physical activity. But we didn't observe this for low intensity physical activity. So here are some take-home message from the current study. In our study, we reconfirmed the previously observed protective effect of physical activity, even we use a different measurement, and also we adjust for genetic risk. And we found out the association was the strongest when physical activity was optionized as MVPA, then followed by total physical activity. But we find out that the association between low intensity physical activity and incident type 2 diabetes was not very consistent, and the effect is quite weak. And also, we want to emphasize we didn't actually find any interaction between physical activity and genetic risk. So come back to the question that I asked at the beginning. I think everyone is very clear about the answer now. I'm not going to repeat it again. Due to the time limit, I wouldn't be able to present the whole details of the study, but we published the paper at the British Journal of Sports Medicine just last year. If you are interested in that, feel free to refer to this paper. Yeah, I think before I acknowledge all the contributors, I want to discuss a little bit about the current and future projects me and with our team are working. So first of all, we are continuing and will continue to do epidemiological studies about physical activity to explore the risk factors of physical inactivity and also the health effect of that. Especially want to pay attention to those disadvantaged groups, for example, people with low socioeconomic status. And also the current and the most recent study we are doing is the Australian system approach to physical activity. And as explained before, we want to apply the system thinking and the simulation modeling to explore a bit more and trying to compare if there will be better physical activity intervention or strategies that can benefit the Australian society better. Yeah, so at the end, I want to acknowledge all the contributors and collaborators, especially my supervisor, Melody Ding. If you are happy to connect or you have any questions, feel free to reach out. Thank you.
Thank you for that very interesting talk. So we now move on to our final speaker. We're into another PhD section. So I introduced Sisi Jia. So she is a practicing dietitian and finally a PhD student at the University of Sydney. And her research explores the influences of meal delivery applications on diet and health outcomes, with a focus on young people, the primary users of these platforms. So her talk is Bite to Bite, how meal delivery applications are impacting the diets and health of the population. Thank you.
Thank you for the introduction. Good afternoon, everyone. I'm happy to share my PhD project here with you all. Humans have gone through many eras of transformative changes. We have evolved from hunting and gathering our own food, preparing our homemade meals, dining out at restaurants, and now we have the luxury of conveniently ordering our favorite foods from meal delivery applications, such as Uber Eats or Menulog. At a few swipes or clicks, we can now get food delivered straight from kitchen to doorstep. Globally, by 2028, it is expected that the total number of users of meal delivery apps will reach 2.5 billion. That's an astounding number of people exposed to an online environment that predominantly offers unhealthy fast foods, which we know may increase our risk for chronic diseases such as cardiovascular disease. Together with my PhD supervisors, my PhD work aims to measure, monitor, and mitigate any potential negative impacts resulting from the use of meal delivery apps on the health of the population. In my first PhD project, I looked at the broader implications of meal delivery apps on sustainable development goals, such as potentially generating more plastic waste, promoting an unsafe and unsustainable gig economy, and promotes a culture of excess consumption and production through the sheer amount of promotion and deals that are offered on these apps. In a systematic review, we looked at how populations across the world have used online food retail platforms during the COVID-19 pandemic. As we know that during this time, restrictions really limited our access to foods. And we found that in 18 of 40 study outcomes, it was observed that majority of participants reported an increase in the use of meal delivery apps. In the next study, we tried to investigate the consumption and context around online food delivery events. So in a sample of 101 participants, we found that young people aged between 18 to 24 years were indeed the highest users of these services. And as expected, they were ordering mostly unhealthy foods. I think the top choice was pizza, followed by burgers and fried chicken. We are also generating the DigiFood dashboard, which is intended to be a monitoring tool to look at how meal delivery apps may be expanding our local food environments and potentially increasing our access to those unhealthy foods. It's still a work in progress, but happy to share some findings on the development later in our next paper. And then in the final PhD project, we're looking at potential ways to regulate the online food delivery space, as we recognize there are potential policy loopholes. So for instance, menu labeling is mandated in stores in person, but we found that it is not well implemented on the online menus through these meal delivery apps. And so it's definitely a loophole that needs to be addressed. I'd like to acknowledge all the wonderful team behind all of this work, especially my supervisors, Dr. Alice Gibson and Dr. Stephanie Partridge, for their amazing support and guidance. Thank you.
So some excellent talks from everyone. So I'd like to invite all the speakers to come and have a seat to the front as we start our 5 minutes of question and answers.
Does anyone have a burning question in the audience?
Hello, I have a question for Susan. With your genetic categorization into tertiles, you assume that each of the SNPs has an equal contribution to diabetic risk, but in reality, the individual contribution of each of these SNPs varies. Did you do a sensitivity analysis to see for those genetic risk factors or SNPs which are most related, did that impact the results?
Thank you.
Yeah.
Thank you for the question. Yeah, due to the time limit, I think I didn't give enough explanation on that. Actually, we not just considering each SNP as the equivalent importance.
Okay.
We use the effect size from the previous JWAS already. So it's a genetic risk score.
Okay,
so,
okay. Excellent, thanks.
Any other questions from the audience?
Neem, I was wondering about when you're setting up your feedback that you then give to the patients with the text at the bottom about the recommendations. How complex was it to develop that text? Because obviously there's a lot of different combinations you can get with kind of more severe and less severe. Like, was it kind of a binary, you're fine / you need to talk to someone about these results, or was there kind of more information that you could put in there?
That's a really good question. So we provided feedback mostly to GPs via the pathology report that they always receive. And we did, during my PhD, an analysis of the reporting pathways that patients have of receiving the results. Essentially, we found that most patients they have the no news is good news approach. So we actually didn't give any feedback about blood pressure or their results to patients through the kiosk, but received a lot of information that patients were a bit miffed about that. So that's launched a whole new program around patient education for my research that I'd love to talk about separately. But for actually designing the text that went on the blood test report to the doctor, we co-designed that with GPs through some additional qualitative work in my PhD, and then also just through small co-design with 3 GPs before we launched the study. So the patients themselves didn't necessarily receive that report.
Just as a quick follow-up, did you have any feedback about how many of the GPs actually implemented the advice?
It's a great question. Kay, my postdoc behind you, is analysing that currently. So we did interview GPs and we're doing an exposure-based response of how many reports did they receive and then how likely were they to action those results in a more qualitative response. And then with the MBS-PBS linkage, we'll be able to look more quantitatively at what the response rate was. Thanks.
We have a minute left of questions.
Thanks. I have a question for Jialing.
Yes.
So your first option was a single cardiovascular pill. Was that a single pill combination for cardiovascular disease?
No, like it can and cannot be, because from the PBS data, we can't really have the daily dose information. So we use the recommended daily dose information from the Australian Medicines Handbook. And we will also validate this by using like EPE, core EPE is like exposure, estimated period of exposure is, we look at the time between two subsequent dispensings to kind of use it as a proxy to know what is the dose, like the duration of the each dispensing.
Yeah. Perhaps something you could do next is looking at opportunities where there is evidence that they're not on a single pill, where there is a single pill on the market that could simplify their medicine dosing.
Yeah, good question, because like the government, the task is very interested in this. So yeah, probably we will look at this because we have the data. Thank you.
Fantastic.
This is just a very quick comment for Sisi. That was the most beautiful way I've ever seen someone summarize their PhD, how it was all linked together. I really enjoyed that.
Oh, thank you so
Well
much.
done.
All right. Any very last? Okay.
Can I ask Dean a question? Dean, you said that Cuba, was it Cuba? Yeah, Cuba's the only one that has their own BP device, and so they don't accept other ones. I asked this question because my mom's Cuban. Is it because they have trouble getting these devices into the country? And have they validated and how have they validated their own device against what standard?
Yeah, so I know I need to be really quick. So yes, and the reason it's because of the import restrictions. Okay. And what they did was they got training through this HEARTS program from experts from Canada, flew in, taught them how to do validation protocols. They developed their own oscillometric algorithms, their own systems, and then they validated it. And once they validated it, then the government basically said, we're only accepting validated devices in primary care. And so now they only have one.
All right, thanks.
Thank you so much, everyone. Can we please have another round of applause for our wonderful speakers? So that brings us to the end of our CVRN seminar today. Big thank you again to all our speakers. And if you're like me, you didn't get a chance to ask your question just now, please stay behind for some networking and drinks and come to our speakers and ask them questions. And yeah, just enjoy the view and the food and the company. And just on the screen there, we've got the CVRN Professional Development Awards are now open. If you're not aware, there's a QR code there that you can scan to look at the details about the award and how to apply. That closes on Tuesday, the 2nd of April. And also there's going to be an EMCR grant workshop on Thursday, the 9th of May. And again, past workshops have always been really helpful. So if you're thinking of applying for HMR grant this year, wait for more information. And lastly, just a plug for our next seminar, which is happening in May, and it's going to be in Newcastle. So please scan the QR code to find out more information, and registrations are now open as well. Thank you very much.